Okay, so here we have, again, here, I'm just going to repeat it. Here we have the PQRST. This picture has everything you'll need to assess it. P wave, QRS, T wave, PR interval, QT interval. And then here you can see the breakdown of the EKG sheet. The most important stuff is pretty much right here. Um, one small square is 0.4 seconds, and one of these large squares is made up of 5 small squares. So that's equal to 0.12 seconds. For the most part, I kind of just go off the number of squares rather than like the time. So when it comes to like what's a normal PR interval, what's a normal QT interval, what's a normal QRS, I just go off the small squares. And then you can also use the small squares to determine heart rate if the um, ventricular rate is regular through the small box method that we'll go over in a little bit. Yeah, so Kalen's asking, how do you know if it's a 6-second strip?
Die. Oh my. Weird. Oh, I'm unmuted. Hi. Hello, everybody. This man went and got water, so I guess it's my turn to talk. Yeah. So if you have 30 large boxes, that does equal 6 seconds. It's going to be important for you if you were to get some kind of EKG strip interpretation question. 30 large boxes multiplied by 10. Yeah, and then you multiply by 10 to get the beats per minute. The heart rate, yep. It'll be important for you guys to know if you are presented with a 6-second strip, because if they were to give you an EKG strip and it's not a 6-second strip, then somehow you like calculate your heart rate and certain calculations you won't be able to do accurately. So like I think if anything, like he'll say something along the lines of, oh, this is not a 6-second strip, by the way. For the most part, most of the strips you are presented with are, but just as a precaution. What is this man talking about? Where is he? He said he was gonna get water and he's still gone. Mm-mm. I don't know how he was gonna do the outline today, so that's why I haven't gone ahead and talked about more. Because I don't know what he wanted to do. I don't know how he wanted to do this. I feel like I should start dancing or something. Oh my goodness. Okay. Diego, are you back? Are you here?
All right, I'm back.
Thank you. Okay. So, because I was like, where'd this man go? So 30 large boxes is equal to 6 seconds. Okay. Straight from the notes. when you have 5 large boxes, that's 1 second.
Oh,
So you multiply that by 6
this is a
to get.
typo. Okay.
Yeah, I was gonna say, I was like, that didn't look right to me, but I was I wasn't sure if you what was going on there. Yeah, so 1 large box is 0.2 seconds. 5 large boxes would be 1 second. You multiply by that by 6, and you get your 6 seconds for 3 large boxes. But yeah, I don't know where you wanted to go with the outline from here, so
Right. So I just have some general concepts for how to assess the EKG. So I have listed down kind of like a decent way to go about assessing an EKG. So I like to start off by checking the R to R. So when you have the PQRST, I like to check to see how, like I literally just take like my finger or when we're testing my mouse and I check to see approximately if it looks like it's regular or not. And you can have the little caltrops thing, little thing to do it on the physical paper, but you can, for the most part, the things you'll get tested on will be easy enough that you could see more or less just by eye. So you can see my mouse. I can just use my mouse to kind of get a general feel for how much distance I'm going. After that, oh, and then here I have listed some of the different things that irregularity or if it's unmeasurable, what rhythms it could be. So you don't have to hard memorize it, but I think it's helpful. So like if the R to R is irregular, could be because of AFib, which causes earlier QRS to happen, on earlier yeah QRS to happen. Some sort of second degree AV block, which is irregular rhythms because of the drops. PACs and PVCs, which are not going to be too consistent, but they will cause irregularity in parts of the strip. And then some other ones, which, if it's unmeasurable, then um, usually you can just tell just from looking at it. You don't really have to go crazy about measuring it. Um, Next, I kind of listed about looking at the heart rate. So that can also tell you quite a bit. So if the R to R is regular, if you determine that the ventricular rate is regular, then you can count the number of small squares, divide that into 1500. So if you were to count everything here, for example, you can also kind of shorthand, every large box is 5 small squares. So you can kind of count like the obvious big squares in between and then kind of add up the little small squares. So this is kind of like a yeah, I'm trying to see if I can zoom in more. Okay, so you can see this is kind of at the start of here. So we can just say this is like one small box, and then we can add one big box, two big box, three big box, five big box. And then this is 4 small boxes. So um, that's the same thing as, so if you guys want to do the math. So 4 big boxes, so that's 4 times 5 plus another 5, 25. So we would be taking 1500 divided by 25, and we get a rate of 60. So if it's regular, we're able to do that. And if it's not regular, then we are instead, hopefully we have a 6 second strip and then essentially just counting the number of QRS and then multiplying by 10 to get 60 seconds. But yeah, if they are regular, then you're able to use this to try to get an idea. And there is such thing as like a ventricular heart rate and an atrial heart rate, but what people call the heart rate is typically the ventricular. But in certain conditions, they won't be matching, so they might be different. So that's all listed there. Is there anything else you want to add, Kalen, or we good from here? Or does anyone have any questions as well so far? Tomorrow we'll go over more specific rhythms and stuff. So after that, so I did the checking if the R to R waves are regular or not. I checked the heart rate. And then after, I like to look at the PR interval. So the PR interval here would come referring back to this is the start of the P wave all the way to the start of the QRS. And then here you can keep track that the QRS starts um, as it's beginning to dip rather than at this little dip point. So PR interval is from the start of this up until this point, right as it's right before it starts to dip down. So that PR interval should be 3 to 5 small squares. You can also think of it again in the seconds, but I think it's easier to just think of it in terms of squares. And for the most part, it'll be pretty obvious, but yeah, the PR interval can help you determine if there's AB blocks. So we'll go over specific stuff tomorrow, but that's essentially why that's a good thing to look at. But because at this point you guys got the in-class lecture and you guys should have seen the stuff. So just to reiterate, the first degree AB block will be when this PR interval is longer than expected, so more than 3 to 5 squares. Second degree AB block, you have two different types. One of them, this PR interval will keep increasing until you have a drop in a QRS. And the other type, the PR interval will be either normal or longer, but it'll be consistent, and then you'll have drops. So looking at that PR interval can be a way of determining some of your AB blocks. And then the QRS length is another thing you can look at. So how sharp or wide the QRS can tell you a few things. Yeah, also if it's dropped or not. Yeah, so Kalen's providing a little bit more context. So whenever you have a drop QRS, it means there's no ventricular contraction because the QRS is specifically the ventricular depolarization, meaning that's the action of the ventricles acting. So less than 3 little boxes, technically, yes. So I believe, yes, less than 3 little boxes is your normal, and anything wider than that implies some sort of issues with the ventricles um, in particular. So your VTAC, your PVCs, some bundle branch blocks, which again, you don't actually need to know. So I'll put that in the, honestly, you don't even really, didn't really come up in NCLEX either. NCLEX was pretty basic, but second and third degree blocks. And I believe he mentioned, or at least he did, I'm sure it's the same test, but he said you guys won't be tested on this for this upcoming exam, the second, third degree blocks on your week 2 quiz, rather. Whatever quiz has week 2, I believe it's more basic, so I don't think he's gonna test you on second and third degrees, but you can confirm with that. But then it'll for sure be there on the final, so you will have to know how to tell them apart at some point. Okay. Um, and then lastly, you have the QT interval, which would be this part right here. So from that same cutoff point, from the PR interval, so the point right before it starts to dip all the way until the end of the T wave is the QT interval. And for the most part, the main thing with this one is when it comes to like the Torsatz points, but you also don't really have to worry about that for this class. But he did mention in lecture that a normal QT interval is 8 to 11 squares, small squares. Okay. You can also check the regularity of the P to P waves. So kind of again doing the whole here, like here to here to here.
I don't know
Okay.
what happened. I just heard screaming in the background on yours.
Yeah, it's kind of loud.
It'd be like that some days.
But yeah, if it's irregular, it could be that second degree Movitz type 1, the Winky Bach, because you have the increasing PR interval that so that can lead to that irregularity. And there's some conditions where you can't, it's kind of difficult to measure. So AFib, you have the fibrillating um P waves, so they're not even, I think they call them what was the, do you remember the name of the fibrillation waves? Is it literally the F, is it, they call them F waves? Yeah, it's basically non-existent.
I believe it's called a F wave. I could be wrong. But they don't really talk about it, nor is it anything talked about in the content.
Yeah. Yeah, so you don't have to worry about it, but yeah, if it's unmeasurable, shows AFib. SVT, one of the ways that you can tell apart like a supraventricular tachycardia from just like a really fast tachycardia, can be that the P wave is if the P wave is hidden in the T wave usually. So I think I remember in the in-class lecture there was one that looked like an SVT, but it was actually a sinus tach. And the way you can tell them apart is because the sinus tach, you could still see the P wave, so it kind of looks like a little like double hump, as opposed to the SVT where it's just like one. So it looks like the P wave and the T wave became one, but in the little sinus tachy, it kind of looks like bump, um, kind of like a, yeah, like a bump, like double bump, like bump next to a bump, like an M, essentially.
Interesting.
It makes sense. Here, let me draw it. I'm actually not very good at drawing the SVT,
Oh
but let's
God.
see.
Well, another way you could tell your sinus tach apart from SVT, and honestly, there are times where it's going to be kind of difficult to tell it, and sometimes you don't even truly know. Um, but something to consider as well as the actual heart rate itself, because your SVT
Uh,
can go up
I'm supposed to just that.
pretty high. What the heck is that?
That's the T wave followed by immediate P wave, or like we, you know. You get the
Interesting.
you get the idea.
Okay. Pop off, queen, I guess.
Yeah, you can also check to make sure that the P is before comes before the QRS. Um, for the most part, that's gonna be more a lot of important for like the third degree AV block because your P and your QRS don't align with each other. With that third degree block, they kind of just go off on their own.
Yep.
So your um third degree AB block actually has both the P to P and the R to R are regular. So with themselves, they are regular, but they don't interact with each other. And in terms of the AV blocks, your first degree is also going to have a regular ventricular heart rate. It's only really the second degrees that have irregular R to R. In general, probably the best rule for this class when it comes to this is the EKG interpretation is going to be fast and symptomatic, synchronized cardioversion, as well as knowing which ones are your rhythms where you do defibrillate. So your pulseless VTach and your ventricular fibrillation. And then Kalen's asking, what is defined as symptomatic? So what are some examples of symptoms people can complain about? Yeah, so the shortness of breath, chest pain, sweating, syncope, pop, yeah, hemodynamic instability. Yeah.
Unstable. Cool. Um, Oh, and then I was also asking for the pulseless VTAC and VFib, why are those not part of the synchronized cardioversion? Why does that specifically have to be defibrillated? Because they're dying. Okay. Yeah, I mean, essentially, yeah. Yeah. Get the jump start, kickstart my heart. And then for those that need synchronized cardioversion, if you were to defibrillate those rhythms that needed synchronized cardioversion, what could happen? Oh, she dying. Miss Girl gonna die. Mm-mm. So always know your defibrillation rhythms. Be aware that of the setting you put on because you can switch back and forth between defibrillator versus synchronized cardioversion. Yeah, you can send them into
Yeah,
full-blown cardiac arrest or send them into a worse rhythm than what they were before.
yeah.
So just food for thought, just food for that.
So if they have something that where they need to be synchronized cardiovert and you defib them, they might be put into here. So I guess technically then you just you have to defib them again and hope it works the second time.
Shock them again. Hey, why isn't asystole here? Diego, don't answer that. Why can you not defibrillate asystole? There ain't nothing to shock.
Yeah, there's no rhythm to shock.
There's nothing to go off of. It's like trying to multiply 2 times 0. You ain't gonna get nothing. Yeah, and at that point, you got to go straight into your compressions.
Yep. Yeah, and then
Yep.
like here we have sick sinus syndrome, which you don't really need to know, but here's information if you're interested. Or if you're in I guess for you is what, PIH Whittier, where you were in the hardcore cardiac unit. You might see something, you might see this.
I saw a lot of weird stuff at PIH Whittier. It was great. I saw a couple. I'd say I saw maybe like in my entire time at Cerritos, I probably saw like 5 or 6 sick sinus syndromes.
Hmm, yeah. But essentially, yeah, like mentioned, it's like a alternating of bradycardia as well as some fast arrhythmias. Could be sinus tach, but it could also be like alternating with AFib, SVTs, can even go into a VTAC.
3 to 5 minutes for epi. Sorry if y'all hear me chewing. I've been snacking on some chips
You know, chips. You don't need chips.
or beef. Oh, to defibrillate them
Hmm.
or something else. Okay, got you.
Hmm.
Oh yeah, because at that point, that person's kind of dead, right? If our ventricle is quite literally fibrillating, or in my head, I think it's like shivering, our cardiac output is down in the trash. They're not going to make it. They're not going to make it too much longer on that kind of rhythm. So when it comes to something like that, if you have the opportunity to shock that kind of rhythm, you're going to want to shock them ASAP, if possible. That'd be nice. Okay, I'll stop talking now. I'm gonna go back to my chips.
So here, it's basically a question for you guys to answer is when somebody has a sudden change of rhythm, what are some things you wanna do? Get an EKG, okay? Yeah, these are all good. That's the patient. Yeah,
That's the
eyes,
patient.
eyes on the
I like
patient.
the idea of a 12 lead EKG as well, because especially if we just have like a regular 5 lead, we might not be able to see some stuff going on. Giving them oxygen if less than
Mm-hmm.
94%. So that's some instability right there, right? That's our patients that are kind of not as hemodynamically stable. Checking the leads. Why is that important? What could be wrong with my leads? That'd be my kind of luck.
Mm-hmm.
They aren't on first and foremost. We love that. Sometimes, the patients be pulling on stuff. Um, they might not be on, they might not be connected to the correct one. I will say that I've walked into a room before and at the I looked at the leads and I was like, okay, red's in the middle. Red ain't
Yeah.
supposed to be in the middle. Like, hold on. Let's let's reassess this thing. Checking on the patient in the room. I mean, I hope y'all would do it. Because we might see stuff on the monitor that isn't inherently true either. So when I say that it's not inherently true, what could I be seeing on the monitor that's not true? If you get my drift. Artifact, yeah.
Artifacts, yeah.
So you might see artifacts. So that's from them moving around a lot, malpositioning. Um, if the connections themselves are bad, like we talked about before, if there's some kind of other electrical activity that the leads are picking up on. So I think one of the examples in the lecture you guys had was if the like the bed or something, if it catches electrical impulse from that, that can also affect it, and it's reading something that doesn't exist. She's lying to us. Assessing the patient, always assess your patient. Vital signs, make sure they're hemodynamically stable. And think. I love that. I do love think. I like thinking. 10 out of 10. If
Yeah, so
A-line assess the site, I like that too. If they, because our A-line, there's a lot of assessments that need to, how did you get that to,
hmm?
oh wait, that's so cool. Is that what was going on? I,
Yeah, yeah.
oh,
But
yo,
yeah,
okay, sorry.
yeah, I'm just kidding. Yeah, so I'll include some of what you guys listed as well. So I have kind of listed check up on the patient. So inherently, you're gonna want to check the patient first,
Pop
just to
off
make
that.
sure they're fine. You can then confirm with the equipment, like if they seem like they're okay. Make sure the equipment's properly working, the leads, vital signs. And then some other things you could look at is then at that point is what are they taking? Um, like maybe they just had like beta blocker or something. It causes like a change in the rhythm. What medications are they taking? What are they not taking? Kind of just look at the trends. What are their labs? What's their potassium like? Their electrolytes that can cause arrhythmias like their magnesium, their phosphorus. So the kidney patients could have stuff happening with that as well. Anything else? So you guys said vital signs. I said patient. I like the whole kind of initiate appropriate protocol. Like yeah, like that O2 if um two is appropriate or insufficient. I like that better. Just because some people are technically COPD, so depends on that as well. Make sure they have IV access. Yeah, it makes her life easier if they do need epinephrine.
Make
If
sure
they
they have
already have,
two.
yeah, if they already have at least one IV going.
Who here actually, who's gone with Robin so far to see the code demonstration?
Cool, cool, cool.
Bro, that's almost like half of y'all in this room. That's kind of crazy. But because you guys got to see the how the medications are actually in the boxes in the package. Because the first time I saw that, I was like, I didn't realize. I don't know why I thought I would have to draw it up myself. I also know that they can have I forget the name of the actual device. Was it the stopcock thing? And you can attach two, but I don't think we have that at Skills Lab.
The which one?
It's like a stopcock thing that you put on the IV and you're able to basically attach both syringes and then push one right
Oh,
after the
right,
other.
right, 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 right. I don't remember what it's called, but yeah, I
I
do
don't
remember.
know if we have it there, but that is something that you could do as well. I don't remember how I got onto IV access. That's how I got onto this. So yeah, making sure they have something that's patent. I know that half the time we kind of push off flushing. It's like, man, it's fine, whatever. But if that thing don't flush and it like you need stuff's going down, and you only have one IV, or the other IV is in the thumb, because let's be real, I've had that before. Um, it's not going to go over too well.
Yeah.
Just food for thought too.
Yeah. That's why you want to make sure you flush. Make sure it's actually patent. And then also flush after because um the IV line has a little bit not actually that's coming out of the patient where the if the medication's still in there, they're not getting the full dose. So that's why you flush to make sure everything inside the line is in the vein.
Gotcha. The little pigtail.
Yeah, the little pigtail. All right. So any questions on this or any questions on anything so far? So any questions on how to read what's going on here? What do these waves correspond to? So the P wave is your atria working, your QRS is your ventricles and whatnot. How much each small square, how much each big square is. If it's AV pace, you would see another. Yes, you would. So let's take a look at that. Um, the
Well, I believe if
pacemakers.
it's ventrically paced, then you're going to see it right before the QRS. If it's AV, you'll see it before the P
Yeah.
wave.
So let's see if this picture is good. Oh, it's hard the level up RM website. It's nice. So here
Perfect.
actually has both. So here you can see kind of what it looks like. It literally looks like a spike.
Ooh,
So you can see here both the atrial spike and the ventricular spike. I'm gonna steal this, so we're gonna just
that's
yoink.
great, actually. That's a really great picture.
Yeah,
I like it, Picasso.
yoink. That's some whenever my thing works. Oh, I think I had to close it to take my test. That's funny. Yeah,
Definitely
so
good to know if your patient has a
definitely.
pacemaker. And another thing to consider with your pacemaker is what is it actually supposed to be paced at? So if it's supposed to be paced at 70 and you walk in the room, the patient's heart rate's 61, something ain't right. SVT is something that should be focused on as well. It can be kind of confusing. I know we're going more in depth in it tomorrow. I don't think there's anything we really have here on this outline today going over SVT yet.
No. Yeah,
Forgive
here.
me.
Now it's gonna be on the picture, so you can kind of see what's going on with that. I mean, I guess we do talk about pace for a little bit down here, but
Yeah.
another thing that's part of your algorithm that's mentioned that you can also look up. So you can look it up. It's the paper that has the left versus right. But it's the H versus the T. So these are the potential causes for arrhythmias or cardiac arrest. So out of these, like how many? Just kind of start listing some out. Let's see what you guys remember. All the H's and all the T's that could cause arrhythmias, um, cardiac arrest. Hypovolemia, hydrogen ion, aka referring to acidity. So having too much acid, that's why your pH. Hypoxia, hypovolemia, yes. Hypothermia, hypokalemia.
Oh,
Yeah, so I'll unlock the numbers. You guys already listed all of them. Boom. So yeah, hypovolemia, which can
so
consist of
smart.
dehydration, bleeding, hypoxia, hypo or hyperkalemia. Just for fun, because I guess this is something that wasn't really truly specified. You'll see your rhythm changes more likely. So even though you want to do something about it when it's off, there are some numbers where it's going to be more likely for you to actually start seeing the rhythm changes. So with hypo and hyper. So correct me if I'm wrong, Kaylin, it'd be like
Oh,
under 3.0 and then above is it 5.5?
I was going to say 5.5. You're more likely to see the changes. You can have a bit of variance. So like your 3.3 might not have any EKG changes. And likewise, there's some weird cases that I've seen where someone with like a 6 point something potassium still did not have significant EKG changes. So weird stuff on that one.
Yeah.
But you're typically going to see the changes in EKG around those points.
Yep. And then you guys already mentioned the T's, so we'll kind of go back up here. So T's
My
for
boy Josh popped off.
there we go. Yeah, T for tension pneumothorax for tamponade, the cardiac tamponade, toxins, so the digoxin toxicity, thrombosis, which can include, your your PEs, your pulmonary embolism. So yeah, cool. And I don't think you have to hard memorize it, but you guys kind of get a general idea um when it kind of comes to what can cause it. So just kind of have the general idea.
I would say like if you can recognize it, that'd be great. Maybe not hard memorize it, but like if you see it, you can kind
Yeah,
of reason with yourself, oh, this makes sense for how this would cause an arrhythmia. So just keep that in mind.
yeah, and then just keep in mind that the hydrogen ion part is referring to acidosis. So not just kind of like if your answer choice doesn't start with an H or a T, it automatically isn't an answer because your cardiac tamponade technically starts with a C, really, and whatnot. So don't just like think of it that way.
Dismiss.
Just yeah, don't just dismiss it that way. Try to be able to recognize the whole word instead of just like is it H or a T. Okay. So the last three things before we get into some questions up here, just making sure kind of like a review on the BLS as well as the ROS, the return of spontaneous circulation, what to do, and then some general education and information on pacemakers. So let's say you are just kind of chilling about to go to class and you see someone just fall over and they're unconscious. What do you do?
Oh my
So
God.
this is just your BLS essentially. So making sure we got yeah. You go, John. Was it Annie? Are you okay?
Annie, are you
Annie, are you
okay?
okay? Check for a pulse. What pulse are you checking? Slap them.
Possible. I mean, I guess
Yeah,
that's a way. I mean, in a
yeah,
worse right, very technically, you could give some kind of painful stimuli, right? So you have your
yeah,
sternal chest rub. Like if
yeah,
you do find they have a pulse or maybe like a weak pulse, and you try to arouse them with with the, with that. That I mean, technically, I guess a slap's kind of on the more abrasive side of things, but it's technically still a painful stimuli.
yeah, yeah. So check the carotid pulse. There's no pulse. Say if no pulse, CPR. So tell me, what is your beats per minute on that CPR? How much are you doing? What does it consist of? 110 to 120 BPM. So,
110, 100. You wrote it down right, but you didn't
oh,
say
my
it.
bad. 100 to 120 beats per minute, and very specifically 100 to 120 beats per minute. I think it used to be taught as just 100 plus, but uh, research research and also gym, it is 100 to 120.
Research and also airway
So,
maintaining your patient too.
yes. Yes, yes, yes. So maintain your ABCs and whatnot. So, yep. And what is your ratio when it comes to compressions versus?
Oh, I was like, wait,
Oh, okay, okay, okay.
that yeah, that one, I believe that one's actually true because it's one squeeze every like 2 or so
Yeah,
seconds. Yeah, I was like that. Yeah, I always thought it was strange, like, huh, why is it so low as compared to, they always told us 12 to 20 is good,
yeah, it's
but
weird, huh?
I always thought that was strange. But yeah,
Yeah,
that do
great.
be right. Out of curiosity, what songs do y'all keep in your head to do CPR to? I just want to know.
Yeah, I do
That
Staying
was like a
Alive.
classic.
I do baby. Oh,
Oh,
really?
is it
Baby shark,
really?
do 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 do. Baby
I think
shark,
the
do do do
AHA
do
has
do.
delegated some songs to it. I think they put a Bad Bunny one on there recently.
Yeah, I do
I mean,
Staying Alive, but I'm not good at following like the rhythm, so I just only do the part where they go and I just repeat that in my head.
no songs to me, just rhythm. He's just going on vibes.
Vibes.
Vibes. In EMT school, they literally play songs while you do compressions for like an hour.
Oh my God. That's a workout, huh?
I
It's
was gonna say,
excuse. It's the excuse to work out.
yeah, I was gonna say, put me in EMT school because Your girl's getting chonky over here. Because I can't go to the gym because my car broke.
All right, so now let's talk about when they actually get the AED. What's the first, like the first step with an AED is turning it on.
Oh,
Um,
true.
yeah, so when the AED is on and the rhythm is checking, what do you have to do? Yeah, listen to instructions.
We just did our ACLS class this past month, and the lady was literally like, just turn it on and listen to it. It's telling you what to
Yeah.
do. As pictures can't miss it. True.
Yep.
Now, let's say you have a child down, and when you go and get the AED, you all you got is the adult size pads. What you gonna do?
This is a you world question.
Was it actually?
Yeah.
Yeah, they do have little, if they have the small pads in there, they'll have little pictures on that for the little peoples. But let's say for some reason the one you get, yeah,
Yep.
one in the front, one in the back for the kids. You don't
For the
want the pads to be touching.
for the demon spawns.
For the
Um.
ah,
Right.
terrible.
So yeah, just make sure with the AD, it's not when it's detecting a rhythm, you have to stop CPR, or else
Don't
it's
touch
not.
them.
Yeah, it's not really gonna detect the rhythm very well. And then especially, I think this is a Kaplan question. It's like, when you're about to, what's the most? I think it was like, what's the most important thing when you're about to deliver a shock? And they give you four right answers, and but one of them's like extra right. It's like,
I was gonna say, I hope it's what I think it is.
yeah. Well, it's not to say clear. It's to look and make sure no one's touching.
Nah, if they're touching, that's their own fault. I'm agreeing with Josh. I'm stepping away.
Yeah.
If you're touching the patient still, I'm gonna yell clear, and then that's on you. Then that's on you. No, don't do that.
No.
Being very mindful of lines as well. I think I can't remember seen it. I believe they also said if you have like oxygen on them, like let's say for some reason right before they went down in the hospital they had a nasal cannula on, that you would want to take that off. Let's just start a fire, shall we?
Not another one.
And our LA's on fire. I don't need another part of LA on fire.
Yeah, I'll say this. Boom. Da, da. I feel like no, he didn't do that, did he? Did he do that?
Pulling the CPR lever on the air mattress, because let's be real,
True.
honestly, I didn't know that was a thing until my fourth semester, because I remember thinking to myself, okay, well, in the hospital, like imagine the head of the bed's all the way up at like almost 90 degrees and you're trying to put them down. It's like, hold on, Jerry, we'll get to you eventually. And you're slowly going down. Like that patient's gonna die. Yeah, the big old red
Yep.
signs. Some have like a button and then pull it. Some you have to push it in and then pull. I think I
Yeah,
don't remember the ones at the skills lab how they are, but every hospital is slightly different.
they're push and
Um,
pull.
is it push and pull at
Yeah,
school? Okay.
there are two buttons, but you only have to press one. So people were trying to press both and they couldn't do it because if you press one, it like pushes the other one to the side. So it's just push one, pull.
Cool beans.
Yeah. And then if you can get the backboard, you should get the backboard.
Or what if you can't get a backboard? What else could you use?
This is the question for you guys.
Let's just say Diego was running with the crash cart that had the backboard on it, and he got stuck in the hallway and he couldn't get there in time. So like, what are we gonna do? What else can I use? The floor. I mean,
True, technically.
technically, I could use the floor. You aren't wrong. A draw sheet.
Not hard enough, but so you know how actually no, you guys haven't done vents yet, have you? Um but like
We
one of
might
the
have talked about intubation. Oh no, just kidding.
no intubation. Yeah, but the headboard of the bed can actually detach. You can just pull it out and you can technically use that as a
A
backboard.
solid surface.
Yeah.
I like the idea of just like, hold on, Jerry, throw you to the floor. We got you. Don't worry. I mean, heck, if all else fails, I mean, you gotta do what you gotta do, I guess. I like it.
All right. Now this is something. I guess he actually went over with you guys in class. He kind of just did it with the other session for us, or like the one on like not one on one like small group thing with us, but it's like what to do
Code.
after, yeah, with the little code thing. It was what to do after you're doing CPR, the patient then manages to have that the ROS, the return of spontaneous circulation. And it's like what do you do? So what to do after ROS? Let's say um like awake versus comatose. Patients got spontaneous circulation, but they're comatose. Do you guys remember anything about what should be done in the during the situation or have experienced it?
I like the idea of checking vital signs. TTM.
Yep, TTM. I don't remember what it's
Fluids.
fluids. Does he still say it? I'm sure he still says it like that.
Fluids like that.
Fluids. Yeah.
Fluids. I love it.
Yeah, targeted temperature management, so that's TTM. Oxygen. I like it. So I have the thing, but yeah, TTM kind of just
Now,
says
why does
other,
that work? I really thought you were gonna write fluids out like
yeah,
that.
brain CT,
I like the idea of brain CT.
EEG monitoring.
But
So
yeah,
these
so we
are,
have,
yeah,
sorry.
go for it. Sorry.
R. So with the targeted temperature management, because I didn't know the reason initially, like why it makes sense. It helps with anoxic encephal. These are big words, Ryan. These are big words. Cold to wake them up. It's rather that you kind of want to keep them a bit more comatose, so to say. The idea behind it is if you cool the body down, you create less damage to the brain because you're able to slow down the metabolic processes.
Yeah,
So basically you throw the metabolism down into the trash, so it doesn't require as much energy to function. You
yeah,
put them in low power mode.
kind of, yeah, pretty much.
Kinda.
Similar to why, I guess like morphine, it can like for like morphine and Mona, like a reason is because it slows down, decreases the amount of oxygen needed for the body during like a heart attack or an MI. So similar reason, you're kind of like using the cold to depress the CNS.
Get depressed.
And I don't believe you need to know the temperature, but just in case, let me see. It's 32 to 36 Celsius, but I don't think you need to know it. What is that in Fahrenheit? No clue.
Let me see.
36 is approaching like normal. 36.8 is normal.
36
So
is 96.8.
yeah,
Said you could use
fluids.
blanket or fluids from the fridge. Yeah, so that's something you could do too. I think at PIH they had in the ICU they had a specific like device, blanket device to put onto them. I don't remember the name of it at this point though. If you look it up on their site, it actually shows up though. At least the last time I saw it.
Yeah, the algorithm honestly just says appropriate critical care management for awake. If you guys want the picture, I don't know what they mean by that, but
Well, just anything, it's keeping
yeah,
them
yeah.
hemodynamically stable.
But very specifically, you may or may not have to know this. Anyways, moving on. Although keep in mind again, this content won't be for the immediate quiz that's happening. They skip over week 2 unless they change that for you guys.
I looked at their thing, it's the same as us.
Okay. Yeah, so this will come back for the next one. But
Next
it
week's
is
exam.
next week's exam, but it is like a big enough piece of content that summarizing it down as much as we can and then trying to get used to what's going on as early as we can is going to be good for the test. Because then that test is what, week 2 and then week 3 as well. So week 3 does with hemodynamics. So hemodynamics, cardiac,
The inflammatory cardiac
mhm,
diseases.
and then this on top of that. So just kind of making sure we got all the important stuff out of that like 166 page PowerPoint. So Last thing before we kind of do questions is general interventions for
Wait.
what
Oh,
happened?
never mind. Never mind. I thought you were going into questions. I was like, you still have the other thing to go. Okay, never mind, never mind. Sorry.
Yeah. Okay. Here, just some some things that could be important. I don't know why that's here. Pacemaker versus AICD. So going over the AICD first, that's a automatic implantable cardioverter defibrillator. So it's something that can both do synchronized cardioversion and then detect defibrillation. Oh, sorry, detect a shockable rhythm and then also defibrillate. So it would be those given to those that are at high risk of having lethal arrhythmias. So maybe someone with a sick sinus syndrome that we talked about that they can kind of go into VTAC or uh, like AFib with RVR, SVT, and whatnot. But then we also have the pacemaker as well. So the generic basic pacemaker. What is it used for? What are things to do and not to do? What do you have to monitor, and what should you report? And I think this one might kind of overlap with one of your questions, Kaylin.
Oh, I was gonna be so mean right now.
What? What'd I do?
I was like, who's Kate?
Huh?
I heard you say Kate, and I was like, who's Kate?
Oh, I said Kaylin.
Oh, goodness, gravy. I'm having too much fun. Okay. Limiting activity, report dizziness, avoid magnetic fields. The microwave's okay though. Difficult breathing. Do not go into the water.
Yep.
Don't swim under the water.
So let's kind of go down what everyone said. It said limit activity. So kind of specifically, teaching kind of similar to the pick line is do not lift I guess implant like arm. I guess in this case it'd be the left arm because that's where the pacemaker would be. Um, arm above shoulder. Yeah, do not submerge the pacemaker. So don't go into water. Exactly. Inform your dentist if you have pacemaker for MRI. Yes. So with your MRIs, be very careful. And I think early on, yeah, avoid magnetic fields kind of goes with it. Educate how to take radial pulse. Yes. So definitely you're going to be reporting any pulse rates lower than the pacemaker settings because that means it's not really working effectively. So yeah, education. Avoid tight clothing, yes. So making sure that, and then all kind of used for, so bradycardia. So people with bradycardia, they can get transcutaneous pacing, and if their bradycardia is constantly symptomatic, then they can get a permanent pacemaker. AV blocks, maybe AFib if their medications that they need is causing some bradycardia, sick sinus syndrome. Just
Monitor
ex
bleeding and
Yes,
hematoma.
exactly. So yeah, we're gonna monitor for hematoma, bleeding, infection, because we did an invasive procedure. Perfect. Yeah, so if you guys get some sort of select all that apply for this, seems like you guys should be able to get it all right there. I think that's everything for now. Any questions on anything before we go into questions?
Wait, what about the AICD?
The AICD, kind of already kind of listed here.
Okay.
I didn't really add anything else.
I was like, this girl, wait.
All right. I think maybe, oh, I think that's what that was there for. I kind of just did others, just like for AFib. So the patient might be on Coumadin, amiodarone taken daily. Although a lot of them now might be on, no, yeah, ASCD is permanent. Um, I think usually now they're on not no longer on Coumadin too often. I think usually now they're on what was the name? What was it called? My brain's kind of not working. Eliquis, yeah. They're on Eliquis usually now because it requires less I wouldn't say monitoring, but with Coumadin you have to get the blood labs, so the Eliquis you don't really have to, but it is more expensive, the Eliquis.
Eliquis is more expensive, and there is technically a blood test that you could do for it, but it doesn't mess with the regular coagulation panel. Whereas your
Hmm.
Coumadin, your warfarin, you would have to be doing INR like every week or 2 weeks. I always forget. So very frequent monitoring of INR and very frequent dose changes if it is out of range. Good stuff, fun stuff.
Yeah. And with your Coumadin, you have to remember your teaching. So the antidote is vitamin K. The patient doesn't have to stop eating vitamin K stuff. If anything, they have to just be consistent with it. Yeah, that's pretty much it.
Partisan, if it's AFib with RVR, I think it helps the ventricles contract at a normal rate.
Yeah, so they could be on that as well. I'll add that on there. So cardizem. All right. And yeah, we'll go over more details of specific rhythms tomorrow. So I'll show you what I have, I guess, cooking.
Let them cook.
I'll show you what's in the oven. So for tomorrow, this is kind of what we'll be doing before we go into questions. Every rhythm and then kind of what to do, interventions. Again, just having all that big 166 page PowerPoint into just considerably smaller things. And then also we talk about the stress test a little bit, but focus more on the pictures and I'll have pictures. I'll throw in some pictures as well in the interventions, your algorithm, and some of the keywords that are highlighted should help a lot. So, make sure you know what can be defibbed, what has to be synchronized cardioverted, and you should do just fine. All right, go ahead, Kaylin.
Yay. So initially we just have a basic interpretation. As it goes down, we'll go into more specific stuff. But for question number one, it's just selecting options that you believe describe the rhythm above. So we could see this. You're going to determine if it's, your 6 second strip. Is it regular? Looking at PR interval, your QRS, the like, what kind of rhythm it is. I'm pretty sure you guys would be able to get this. Okay. I looked back at it and I realized how many answer choices there were, and I was like, oh,
Yeah, it could be worse. I don't think it did it with your class, but I
no,
think it was for 222.
yep,
I gave them a select all that apply. I think it went up to like O.
you're horrible. I remember that session too.
Yeah, and I told them I was trying to get it up to Z, but I kind of was like, whatever.
I fear for the day you're a teacher.
I thought it was funny.
I feel like you'll troll people.
And if you want, we could also just go into each individual one and kind of test it out. I'll give you
Yeah,
guys a little bit more to try to kind of figure out what's going on. And then after I get a few answers, we'll kind of go through it together, trying to again incorporate that order that I do, I guess. I mean, not you don't have to do it in that order. That's just how I do it. All right, we got two who seem to agree. Probably wait for two more. All right, we got Kyrene, also agrees.
Okay.
One more person. And then don't be influenced by the chat. Just kind of do your own thing.
Josh,
Oh yeah, no more.
oh boy, you're always working. I'm worried about you. I'm getting real worried about you. I mean, get your bag, but I'm worried.
All right, so yeah, let's go through it. So that just for clarity, yeah, it is A, C, E, and I.
Yep.
And the way I kind of go through it is I start kind of just looking. What's the ventricular rhythm? Looks pretty regular to me here. So we know it's not B because it's regular. I check to see the heart rhythm as well. We can check to see if this is a 6 second strip. Is it, Kaylin? I don't feel like counting squares.
It is.
All right, so in that case, we could do the easy way, which is just 1, 2, 3, 4, 5, 6. So this is 6 times 10. Um, da, da, da. We can go ahead and look at the PR interval. Kind of hard to see, but you see that this is definitely less than 3 to 5 boxes. So it's definitely less than a large box. So that PR interval is within normal limits, and it doesn't seem to increase at all. So for
Very
now,
consistent.
yeah, very consistent. Then we can check the P to P, looking good. So we can definitely say it's A. We can say that the PR interval is within normal limits. We can take a look at the QRS. That QRS is definitely less than 3 small squares. You can see it's pretty much like barely above 1. It's not a wide one, so it's definitely not D. Equal atrial and ventricular rate, but there is always a P. There's always a P before each QRS. They go with each other, so it's definitely E. We set their equal, so that's definitely the F is not true. We set the PR interval was consistent and it was within normal limits, so that can't be that. Um, and 60 is within our normal limit for heart rate, so this is normal sinus rhythm. All right, cool.
Yes.
Number two.
All right, so you see this rhythm above on your monitor, you do a pulse check and your pulse is present. What action are you doing next? Or what's most appropriate?
Yeah, and since this is the same picture, we kind of already know what rhythm this is.
Oh, wait, was
Um,
it? Oh, my
yeah, it's the
bad.
exact same picture. I told you this.
Ow, sorry.
Yeah. So instead, what we can also do is kind of look at the answer choices and then ask what would be an appropriate when would B be appropriate? When would atropine be appropriate? What kind of rhythm um would atropine be expected to be given? Yeah, with like a Brady. So specifically, usually with symptomatic bradycardia. So keep in mind that some people just have sinus brady with no symptoms, and that's just their normal. So
You.
me with my hypothyroidism,
Yay.
uh, and go to the gym sometimes, but people who are very athletic runners, um, go to the gym a lot. They
My
can
dad.
have they can have sinus bradycardia.
My dad
Yeah,
didn't go to the gym and he's like a chain smoker. Loves his steak the whole bit, but he's worked a very physical job for very many years. So I remember there was a time we thought he had a heart attack, so we were at the hospital. He was fine. Don't worry. First and foremost, he was fine. And the darn monitor kept going off because his heart rate was 42.
oh my God.
And I was sitting there and I'm like, hey, Dad, how are you feeling? I'm feeling good. Why? I'm like, are you lying to me? You just want to get out of the hospital, don't you? No, I'm not lying. As I never knew how low his heart rate was. Apparently, it's really low normally.
Interesting.
Yeah, good times.
I do remember that happening, but I didn't know it was 42. That's crazy.
Dude, yeah, I was in the 40s.
Yeah.
I'm like,
So chest compressions, when's it appropriate to do chest compressions?
ass this Louis.
Ah, systole.
I'm sorry, it caught my attention.
Yeah, and then also with pulseless electrical activity. So I don't think you went too detail into that, but
I'll,
meaning that like actually technically, like let's say this question literally said no pulse is present,
okay,
then
Mala.
then you'd want to start compressions because in that case the patient doesn't have a pulse, but the EKG shows that there's electrical activity, but there's no actual pulse happening. So you would then have to do your chest compression. So your PEA and your asystole have are both part of that the right side of the algorithm. While your BFib and your pulseless VTAC are on the left side, they have their own little differences that we'll talk about tomorrow.
Tomorrow.
And then activating the emergency response system kind of just goes with the patient likely having no pulse and
Not
um,
doing too hot.
not doing too good. Yeah. All right. So
Yeah.
let's look at number 3.
What is the rate of the rhythm above? My dad just came in the room. I should have asked him if he remembered the time where I was freaking out because his heart rate was 42. But yeah, this one's pretty straight up, right?
Yeah.
So making sure first and foremost, because let's be real, if they finna trick you, they finna trick you. So making sure that this is a 6 second strip, so making sure we have 30 boxes. Newsflash, there is 30 boxes, don't count them. I don't want you guys to count them because I'll feel bad. But making sure it is a 6 second strip. And then at that point, you can count the amount of QRS you see there and multiply that by 10. So I see, was that 5? 5.
hmm
Multiply that by 10, you get 50.
Yeah. But if they cut off this little piece right here, it's completely gone. This little piece is gone, and you don't have the full 6 second strip. Then you could also again count the squares. So here we would just kind of take your R, find this other R. I like to just count the big boxes first in between. So 1, 2, 3, 4, 5. And then I try to count the small squares. So this feels like it starts right over there. I'll zoom in extra hard.
I was gonna say, just zoom in. There you go. Make
Yeah,
your life
so I would
easier.
say maybe like 1,
Girl.
2, and then 3, 4, 5, 6. So how many picks did I say? 1, 2, 3, 4, 5. So let's take 5 times 5 plus 6, 31, I suppose. 1,500 divided by 31. It's not it's not the most accurate method, but maybe I had an extra one. Let me see if I do 30. Yeah, if I did, I think I counted an extra one. If
Ooh.
it's 1,500 divided by 30, you do get 50. If you are off by that one because of it's not, it's not always going to be the most accurate, then you get 48, but then there's no 48 here, and the closest one is 50, so you would just press the 50. But that's just to make sure you remember the small box method, how to do it. So it's 1,500 divided by number of small boxes in between. Okay.
Yay.
Okay. So now let's look at 4.
All right, so your patient is experiencing this rhythm. They have a blood pressure of God, 70 over 42, mental status changes, and is clammy and pale. Pulse is present, and you are going to prep the patient for what? I know we didn't go too far into this. You guys will be fine.
Yeah, so you guys all went with B. So yeah, that's correct. So here, the main key factors here is that this person is clearly symptomatic, um, but they also have a pulse.
Just for kicks and giggles, right? What rhythm is this? 'Cause y'all had the lecture on it. It is not SVT.
It is not SVT,
I'm
it's VTAC.
sorry.
Hmm.
It do be VTech. I was like, I'm sorry.
So
I'm
the
sorry.
the definition of VTAC, or not, I guess there's different
Oh,
types of
try.
VTAC, which can make it. Yeah, this one's a sustained monomorphic VTAC. Again, you don't need to know all that detail. Don't worry about it. But VTAC, the typical presentation is either you can call this a sawtooth or the tombstone. It looks like a bunch of tombstones because they finna die.
Oh,
But
I always thought they looked like clouds, but I guess
clouds.
tombstone. Well, I mean, sure that they could go to the clouds then.
Oh, true. Or they
Mm,
could get this kind of looks like they're about to get bitten by like a shark. But or kind of I think
mm,
it looks like tombstones. But yeah, and there's different types of VTAC. There's technically a non-sustained. So sustained just means that
constant.
it holds this, yeah, it holds this consistent tombstone pattern. Non-sustained means it kind of maybe goes back slightly and then comes back to this and then comes back slightly. And then the polymorphic. So if you guys recall, so the polymorphic, one of the polymorphic is torsades to points, which you don't really have to know, but because it kind of looks like BFib a little bit. But um,
It
don't
is
worry about
confusing.
that. You won't get tested on torsades to points, so don't worry about it. But that is a type of polymorphic VTAC. But yeah, so here the keyboard is at pulse. So fast and symptomatic, synchronized cardioversion. So as long as we remember that, we'll be chilling.
Cool. All
So
right, so then
now,
on to number 5. I just put what is this rhythm? I just realized I didn't put anything else for that one. Why is it so close to number 6? I guess I was
mm,
going through it today. I don't know what
so I
happened
will
there.
zoom in here. Boom. Oh, that zooms in a little too
Too
much.
far.
There you go. Yeah, so this is going to be a sinus, yeah, sinus Brady. So we see that the R's are even or regular. So it's sinus rhythm. There's a P before a QRS, so it's sinus rhythm. And then it is a slow, I believe it's a 60-second strip. So 1, 2, 3, 4, 40. So definitely Brady.
It is.
And if it wasn't a 6-second strips, then we can look at our method. Here it kind of
Yeah,
looks like the start of this kind of starts directly on this big box. So let's say one big box, 2, 3, 4, 5, 6, 7. So 7 times 5, 35. And it looks like it has another 3.
yes.
So 1500 divided by 38. Oops, about by 38. About 39.4, so about 40, which if we
Wow.
knew this was a 6-second strip, yeah, it's about 40. So you could see it that way as well. Yeah, if it's symptomatic, then we give the atropine. So keep in mind, I mean, I'm sure, I mean, I guess your dad was at 42 and he was not symptomatic, but just keep in mind
No.
that you technically don't have to do much if they're not symptomatic.
Oh no. Yeah.
Yeah,
I mean, like for example, some people's heart rates really drop down in the middle of the night. For myself, I dropped to the 40s. But one, I'm asleep. So patient condition, right? Are they actually awake? Are they active or are they sleeping? So a lot of your patients' heart rates are going to go down when they sleep because you don't need as much energy to do stuff while you're sleeping. They could be an athlete. I'm
yeah,
going to just claim that I am. And
uh,
sure, that's why my heart rate's low. Mm-mm. Or you could be like Diego and have hypothyroidism. The like. But if,
yeah,
they function well at that point because their cardiac output is maintained, then there's no real indication to do anything. But
yeah.
yeah, that one's pretty straight up.
Number
I tried.
6.
I try to make these not too cruddy. Number 6, a patient has just returned to the cardiac care unit after having a permanent pacemaker implantation. For which potential complication should the nurse most closely assess this patient for? Bro, why?
But how does she know that?
Huh?
I didn't know she knew. Oh, must probably UG. Oh no, sorry, never mind.
Who knows what?
Nothing.
Oh my gosh. Spill the tea, sis. Spill it. Spill it.
Huh?
I was like,
Oh no,
spill
no,
the
don't
tea.
worry about it. Don't worry about it.
Live your best life, man. No, it's not a select all that apply. It's one of those where it's like, there might be some that are right, but which one's the most right? Because we just love nursing school, and we just love the fact that they like to test like this. Feel like I will say though, I know I've always seen people post from other programs, and they say that it's almost every test that they feel like there's several right answers, but they need the one that's the most right. I don't feel like I felt like that very often here. Like every so often, sure. But it didn't feel like every test I was like, man, they really screwed me over.
What happened? Did we finish 6? Sorry, I was looking at something else.
We're all paying attention. No, we're still on 6. Cool. Anyone else? If not, it's okay. It's okay, we'll talk about this. Yeah, so for number 6, the one that you're most likely to be assessing for immediately after their pacemaker is bleeding at the implantation site. So bleeding, infection, um, anything of the like immediately after, we would be looking for the chest pain, the bradycardia. We can also look for those. Not to say that it won't happen. It could happen, but what's the biggest complication there would be the bleeding at the implantation. Is that the right word? Yeah, implantation site. And infection, which infection's not here, but infection is another big one to be assessing for. Um, yeah, let's see. Yeah, that's pretty much it for that. Scroll down, me boy.
Okay. Number 7. So this was with the ICD.
And
So what is
that's
the
kind of,
purpose of the ICD and what is your best response? So let's see what we got.
I was gonna say, I realized you didn't go too far into any of the pacemaker ICD, AICD, etc. Okay, I finished a whole bag of marshmallows. Bro, I love going to the grocery store and smelling like the aisles that have the marshmallows. I could be 2 aisles down and I'll smell the marshmallow and I'll know exactly where it's at. I love them. I love Peeps. I'm excited for Easter because like the Peeps come back around too. I know a lot of people don't like them. I like them though. It's important to me. What about you, Diego? Do you like Peeps?
No.
No. Okay, well if you
No.
get any, just shoot them over to me then.
That's fair.
Cool. Oh, marshmallows with popcorn. The little popcorn balls. I love those too. I love the Reese's peanut butter eggs. I went to Sam's Club the other day and they already had a lot of Easter stuff out. And they had that too, and I thought about picking it up. But I was like, man, we didn't even get to Valentine's Day yet. I need to relax. These are dangerous. They're dangerous for my waistline. Give me metabolic syndrome. It's over. It's so over. Honestly, yeah, I'll sit there and I'll eat the whole bag if you let me. So I have a problem. Oh, wait, can you go back? We're on 7, sir.
Oh,
This man ain't even paying attention. Look at him. Oh well. But yeah, so for someone who just had an ICD, you're going to tell them that that is in place to detect and treat dysrhythmias such as VFib and VTach. Whereas your pacemaker is used for things like bradycardia because it's pacing it. Your cardioverter, defibrillator is to help put you back into the correct rhythm. So yeah, cool beans. Answer for that one was A. Now we're on number 8,
oh,
sir.
yeah, number 8.
Sir.
Number 8.
The nurse is planning discharge teaching for a patient with a newly inserted permanent pacemaker. Wow, I put a lot of pacemaker questions here.
It's
What is the
good to know.
priority? It is good to know. What is the priority teaching point for this patient? Because like I didn't realize that you could have like the pacemakers interpreted. I had no idea what that was, and then I walked in the morning, and they were basically like sitting there with the machine and like testing it. I was like, "What's going on?" I saw it for the first time, I think in 240. I was very confused. I didn't know. I didn't know no better. Nobody told me. Oops. Imagine being like you can never go to a store again, because those anti-theft devices that are gonna start beeping at you if you walk out, like it's over. It's gonna be beeping and you're gonna be on the floor. I'd cry. Well, beans, guys. Yeah, so no high voltage electrical generators. Your microwave is fine. It doesn't emit enough stuff to cause any harm. Um, some other things to consider, like pretty close after it's been inserted, because this patient has a newly inserted one, they should not be lifting their arm. They shouldn't be doing their arm exercises or anything for a little while after placement. Could be a week, could be several. Um, Apparently, I just found out anti-theft alarms may be triggered, so patients should be taught to walk through them quickly. I did not I didn't know that was a thing. I just found that one out recently. You don't have to know that, don't worry. Let's see, is there anything else on here? Oh, but they don't interfere with the pacemaker function. That's it? That's it. Okay. Yeah, that one's pretty straight up. C
All
on that one.
right. So let's go to number 9.
Number 9. The ED nurse is caring for a patient who's gone into cardiac arrest during external defibrillation. What action should you do next? Or what action should you perform? Excuse me. I have a chicken pot pie. So excited. Oops. Y'all, this is super random, but then I know we were talking about like Easter and stuff. And my mom, she was like really into making the Easter baskets, right? If any of y'all have kids, don't put me on speaker right now because I'm about to talk about the baskets. Right. Oh yeah, she would like make these really extravagant baskets when I was growing up. I mean, like it was all Dollar Tree stuff, mind you, because let's be real, it's hard out there. But like she put a lot of effort into those things, and looking back at it, I was like, wow, like I thought they actually came from the store. I still think they came from the store because they looked good. I need to ask her like tricks for that because I'm not very good at making stuff look bougie like that. Mm-mm. I burned my mouth.
Are we on the next one?
No.
Oh, okay, cool.
Pay attention, sir.
I'm texting a
Anyone else for
friend
number
though.
9? You'll get your wish soon, okay? We could go to the next one soon. Jeez.
I want to press the
Rushing me.
button.
He's rushing me.
No.
Oh, yes. Yes. Okay. Number 9 is going to be B. So ensure no one's touching the patient at the time the shock is delivered. If they are, that's on them. Nah, don't do that. But yeah, so making sure both paddles are on the front of the chest, Observe 2 safety measures. First, maintain good contact between the pads and the patient's skin. And second, make sure no one's touching the patient and no one's touching the bed. So don't touch the bed, don't touch the patient, don't touch anything. You stand away, Miss Girl. Let's see. And ventilation should be stopped during defibrillation because also that person should be stepping back as well. Okay, now we're on number 10.
Wow.
Star.
My favorite. All right.
He's
Make
so
sure not.
shady.
Hold on. Ugh, perfect.
Good
And there's
job.
a number 11, which I can't wait to get to.
10, we'll do it again. During a CPR class, a participant asked about the difference between cardioversion and defibrillation. What would be the instructor's best response? Oh, I almost dropped my pot pie. You almost made me drop my croissant.
Oh my God.
Good times. I miss Vine. You know, talk and then TikTok died for a second, then it came back. But you know what? Vine walked. He said this one easy. Okay, girl.
True. True. Technically, I think there's a Kaplan question about because boop, boop, boop. Yeah, I wouldn't be surprised.
I hope so. I hope so. Wait, I am seeing this right, right? Or am I tripping out?
Are you tripping out?
Am I tripping out? The answer I put the answer I put down was B, but I see A. I see people saying A. What's A?
Well, I think that
Cardioversion.
was enough for the last. Oh no, that was enough. I don't know what the last one.
Wait, I did something wrong. Cardioversion is done on a beating heart. Defibrillation is on. I mean, I guess technically that's well, because you're actually no. Defibrillation goes for VTAC, both pulseless and pulse, right?
No, just pulses.
I need to change this question then. Well,
Oh, I get what you're getting at. The main difference is that one is literally the cardioversion is going to be synchronized to the R on every
okay, so
R.
this one's a my bad. So I'm gonna change the answer choice on this. My bad. The intent.
Just change defibrillation versus
I'm sorry,
no,
Josh.
just change the order of the fib and cardioversion on that.
Oh, you're smart.
I think that's probably what you meant, but then you did it the other way.
I'm sorry. It's been a day. I'm
Girl,
sorry.
girl.
I'm sorry, Josh. I failed you. I didn't mean it. The intended answer was B. So your timing of it, because you know how I was mentioning earlier, if you were to defibrillate a patient you're supposed to do synchronized cardioversion on, then you're gonna send them into a really cruddy rhythm. Um, it was gonna go at the peak of your R wave. Let's see. That's pretty much it. You don't
Yeah.
always, well, I mean, you don't really do cardioversion before defibrillation. Not really. I always feel like it's one or the other. Defibrillation is not synchronized. It's just a random shock. Cardioversion is synchronized.
Hmm.
Cool. I think
Boom.
that's, yeah.
Yeah, that's
I'm
pretty much
sorry,
everything.
Josh.
Any questions on anything before we move on? All right, cool. So actually, I'll stop the recording here. Great. I'll stop the recording here. So there is one more question, but I guess the people watching at home, uh, they'll have to wait. I don't know.
That's just mean.